with Dr. Benita Zahn.
And good morning. Welcome to the special edition of Health Beat. The latest developments on COVID, that's the focus. And it's been a very busy 2 weeks. As of today, there are 3 vaccine candidates showing 90% or better protection against coronavirus. Despite that, the warning about avoiding large groups, wearing a mask, and social distancing, well, that all continues. And the numbers of cases keeps climbing. So we've got 2 experts to answer your questions. Dr. Stephen Hanks is the Chief Clinical Officer for St. Peter's Health Partners, and Dr. Eric Yager is an associate professor at Albany College of Pharmacy. Virology is an area of his expertise. Guys, thanks so much for joining us. And I want to get right to things. I want to talk about the 3 vaccine candidates. 2 are of one type, the Pfizer and the Moderna. The AstraZeneca, which just got, they just released their what looked like very promising results, is a slightly different type of vaccine. All 3 are showing 90% or better at conferring protection. Let's talk about what makes the 2 types different. Whoever wants to jump in, go right ahead so that folks can understand. Go ahead, Eric.
All right. Good morning, Benita. Good morning to your viewers as well. So these 2 vaccines that you mentioned, the messenger RNA format vaccine and then the AstraZeneca adenovirus vaccine platform. So these are 2 novel platforms that have been tested in laboratory settings, but not to this large degree for use in humans. So the 2 vaccine types you mentioned, the messenger RNA. What that involves is basically delivering a blueprint for one of the viral proteins that we know our body makes an immune response to our cells. Our cells then make that protein and our body generates an immune response to it to educate us to that virus before we're infected to hopefully protect us against it. The data that came out this morning on the AstraZeneca vaccine is a cold virus, a chimp cold virus. It's just a different way to deliver the blueprint material to make that viral protein to our cells. So this is a type of vaccine that's been used in other settings. It's used in wildlife for rabies vaccination. It's been used in experimental settings for about 30 years, but again, this is the first time it will be used widely in humans. And this works by delivering, again, that blueprint for that viral spike protein to our cells. Our cells make it, which educates our immune system to generate a response against it.
You know, I've got to tell you, even before we went up, I was following, questions getting posted in comments, and 100% were like, I'm not interested. Keep this stuff away from me, and things to that nature. And I'm sure you've all heard that. A lot of people are concerned about vaccines in general because they're afraid the vaccine will give them the disease. Can you answer whether or not that is even a possibility with these 3 vaccine candidates?
I can take that one if you'd like, Eric, but none of these vaccine candidates can give you COVID-19. We're not using live attenuated vaccine in this situation. So in the setting of the mRNA vaccines that Eric just spoke about, that is not a live piece, a live viral. It's DNA, but just a segment of, or actually RNA, just a segment of it that then gets into your cell's machinery for protein making and makes a protein that then your body mounts an immune response to. So there is zero risk of contracting COVID-19 from that virus, from that vaccine. And also from the adenovirus vaccine, vaccine, which is a more traditional approach that's been commonly used in humans, that the one that AstraZeneca and Oxford announced their results on most recently, also no chance of contracting COVID with either of these.
Question I've gotten from viewers as these vaccines have been coming along through the pipeline is, which one do I take? Can I mix and match?
Yeah, I'll take that one. So that's one of the pluses and minuses. So it's great that, we think back to just 10 months ago, who knew we'd have vaccines, 3 vaccines on the cusp of being put out in the public. There's pluses and minuses to both. Again, all these vaccines have shown high efficacy, which to me is amazing that we're above 90% efficacy. That's fantastic. But there are some caveats. So there's issues with, you cannot unfortunately mix and match these vaccines. Even with the messenger RNA, it's if you get the Pfizer shot, 21 days later, you'll get the second Pfizer shot with Moderna 28 days later. So these are not interchangeable. So that, I think, is going to make an interesting logistical challenge for clinicians and other chains to make sure that the individuals get the vaccine they need. And also, with these vaccines, you need 2 doses. There are some other vaccines that are being tested. So I like to say that this is kind of a long race towards a vaccine. These are the 3 individuals that are closest to that finish line for that first lap. And there's a lot of positives here, but there could be other vaccines in the future that might be a single dose. But these, again, are 2-dose vaccines, and they have some particular transport and storage issues that we have to take in consideration as well.
The AstraZeneca looks to be right now a much less expensive vaccine, and you don't need to keep it just super cold, which gives it a wider of options for delivery into areas that may not be well served by healthcare and technology that the other 2 vaccines need. Dr. Hanks, how will somebody decide, who will make the decision which vaccine, if all 3 get the go-ahead at about the same time, which is the right one for you?
So we'll be following the advice of the public health authorities, and this will come out in the sequence of approvals from the FDA. And because the supply of these vaccines will be somewhat limited initially, and there's incredible demand to get these vaccines deployed, first most likely to healthcare workers, and then also to highest risk populations in the most endemic areas. They'll probably deploy all of the vaccines as quickly as they are able to in particular areas. So I don't believe we're going to have that choice, at least initially on the ground, that I have a patient in front of me in Albany and I can choose the Moderna, Pfizer, or AstraZeneca vaccine. I don't think it's going to be like that. I think the distribution will be controlled, and whatever vaccine is given in a particular area would likely be what's given for some time.
Yeah, that answers. Tammy had asked a question if you're going to be able to choose which vaccine, and it's not going to be that simple, at least early on. Part of the issue right now is if a lot of folks are hearing vaccine, great. I can take my mask, I can throw it out, and we can go on with life. Let's talk a little bit about that.
Well, that could be a potentially fatal mistake. So we absolutely would not recommend that. Until people are vaccinated and or we have total population herd immunity and the spread of the virus has been halted, we need to continue all of the precautions with masking, physical distancing, avoiding large gatherings and high-risk situations. All the things we've been doing, we'll need to continue to do. There truly is light at the end of the tunnel, though. When we look at the capacity to produce all of these vaccines, we do believe that somewhere on the order of maybe midsummer, we'll be out of the woods and this pandemic will be in our rearview mirror.
I see that Eric is nodding in agreement, but go ahead, Eric.
Well, no, I completely agree with what Stephen mentioned. I think the light is at the end of the tunnel, but certainly the doses we have so far are certainly not enough to protect everyone. So we can't just throw out the mask. Unfortunately, as Stephen mentioned, probably until we have more widespread availability of the vaccine, we have to be sure the vaccine is going to give us immunity that lasts a decent amount of time. That's still something that is yet to be determined. So it's great that we have the rapidity in which we get to a vaccine, but there's still a lot more studies that need to be done to see how long that protection lasts. Is this, for any of these vaccines, going to be kind of a seasonal flu type vaccine that you get each year, or is it going to be maybe every biannual, or it could be like the tetanus shot you get every 10 years. We just don't know those answers yet, and that unfortunately takes time. So I think, as Stephen mentioned, the light is at the end of the tunnel, and we still have to kind of bear with some of these non-pharmaceutical interventions that aren't fun, but they're protecting us from this, again, pandemic that's still happening and is still a fatal disease.
Yeah, Debbie wants to know, what about side effects from these vaccines? Are there any?
Well, there are side effects to just about everything we do in medicine, and vaccines are no different. However, the studies that have been done on these 3 vaccines have been largely consistent in that we've not seen severe, serious side effects. The 2 mRNA vaccines do seem to cause a little bit of maybe achiness, almost like a flu-like type of feeling for a day or two. One of them was described as like having a bad hangover for a day. However, people have to keep in mind that each of the trials of the mRNA vaccines enrolled 30,000 volunteers. And the same is true for the Oxford AstraZeneca vaccine. The J&J vaccine, which is also an adenovirus vaccine under development, is looking to enroll 60,000, but they were a little further behind the rest of them. Again, no serious side effects have been noted. However, when you think about it, we'll have tested for these 3 vaccines only, 120,000 patients and not for the full 2-year period that you would typically look to for in the course of the trial. So the full study will continue to run out with post-vaccine monitoring and surveillance. So, it is a situation where we will need to be vigilant and doing monitoring and ongoing study to see if there are other side effects of the vaccine that we don't know about yet. But right now, all is pointing to a very, very safe vaccine. And frankly, I'm going to have no qualms about accepting the vaccine myself.
Any one of the three?
Any one of the three.
So the vaccine may start to roll out in December, but realistically, more widely, any one of these three, we won't really see this till what, late spring?
Yeah, I think it'll take some time. Just to follow up what Stephen had mentioned, the other thing that's important about these studies is that they were very inclusive of different of gender, age groups, and different races and ethnicities. And that's important because we know this is a disease that impacts our elderly individuals. It also impacts certain groups in our communities. So we want to make sure that the safety is applicable to all. And as Stephen mentioned, it's been tolerable in all the groups they've tested. So it's hopeful that this vaccine, as the production ramps up, and as Stephen mentioned, there's certain groups that we want to target first, the ones that are at risk. So individuals that are older, above the age of 65, individuals that have pre-existing conditions, and perhaps, importantly, our healthcare professionals, our frontline workers that are there every day making sure we're safe and healthy.
Now we're talking about, prevention, and there's one question on that I want to get back to if time allows, but I want to talk testing. Many people think, I'm going to go get myself a COVID test. It's going to be negative. I'm fine. I can go get together with everybody. We keep hearing, don't rely on that. Can you expand on why that's not your get out of jail free, if you will, card?
You want me to start on that one, Eric?
Sure.
So the reason that testing is not a get out of jail free card is because it's not 100% reliable, A, and B, the pattern of the virus and the way people get infected and then develop symptoms, the person can be infective and still, especially if they're asymptomatic, not test positive, particularly if they use rapid antigen testing, which has a lower sensitivity than the RNA-based testing with the PCR that you've heard about. So there are different testing platforms that are used in different clinical situations. And so it's nice to have a negative result, but it's not a 100% guarantee that things are just fine. And we've actually seen situations where people have been in the early phases of COVID-19, asymptomatic, have tested negative repeatedly, only to then develop symptoms. And then when you contact trace, you find that they've already spread the virus to 15 or 20 people or more. So that's been one of the unique aspects of this virus is it's very wily, it's incredibly contagious, and testing is not a 100% guarantee.
So how do we know if we're safe? I mean, look, it's Thanksgiving. We want to get together. Maybe we're not getting on a plane, train, or bus, or driving far, but we just want to get together with the kids who are going to drive in, and they all took a test and everybody was negative. How do we know? I think that's what folks want to know. How do we know who's not going to confer this virus on us?
Yeah, it's a quandary, and everyday decisions now become a risk management, an exercise in risk management is determining, what do I know about this person's exposure level? Do they work in a public-facing job? Have they interacted with a lot of people? Have they been following safety practices? So I think what was established early on by health professionals and CDC was really to just think about who you're encountering and kind of have like a bubble, if you will, of individuals you feel comfortable with. And in any situation that feels unsafe, it's just to really follow the overabundance of caution, because unfortunately, this is not a disease where, a number of people you read about and heard about too, like, just went to the store or just got together with friends or just went to a wedding, something that seems pretty harmless. And then unfortunately it leads to them getting infected or them spreading the disease. So until we have, a better handle on vaccines being more widely available, I think unfortunately we do have to follow this overabundance of caution and really take these levels of precaution with even everyday activities that, just 10, 12 months ago, we never thought much about, a risk of getting a cup of coffee, a risk of going to a restaurant, is really thinking through what's safe for me to do really what's safe for me to do for other people in my family and my community.
Yeah, I'm sure I share confusion with a lot of other folks. You know, we're told you don't have to wipe down your groceries and other items. It's the aerosol, the way the vaccine is spread. So then why are we told if you're going to go to somebody's house, bring your own utensils, plates, you know, things of that sort? That's like a mixed message.
Well, I think that goes in, using Eric's phrase, an abundance of caution. That's where that falls in. There's not a lot of evidence that there's a large degree of contact transmission. In other words, picking this up from a surface. But theoretically, it can happen, and we do believe it probably does happen in a smaller number of cases than either the droplet or aerosol method. And so, out of an abundance of caution, that would be the step you would take to always decontaminate surfaces whenever possible, separate eating utensils and things of that nature.
And so that's if it's on your hand, you don't rub your eye and voila, you've now transferred the bacteria. Excuse me, the virus. One of our viewers, Tammy, also says, you know, throughout history we've had to roll out vaccines en masse. So what have we learned that can be applied now?
In terms of like what we know now from the past few months, I think we have a better handle on.
I'm sorry, Eric, let me jump in.
How this virus is transmitted. So really the initial information was what do we know about other respiratory viruses like the coronavirus, and that it is a respiratory virus and that touch transmission can happen. The concern about aerosols, you know, was always was present, but then became to the forefront as more data was released. So I think it's been, I don't know if I want to call it a silver lining to this, but really this is the amount of papers that have come out in this 10 months are hundreds of thousands, if not just all these studies happening, that we know more about this virus now than we did before. We know potentially about therapies against it. We know vaccines are close to being released. And I think from a clinical standpoint, clinicians hopefully have a better handle on what benefits the patient, and also identifying which patients are at risk and how to educate those patients on behaviors to keep them safe.
The question was more geared towards, have we learned anything about rolling out, doing a big mass vaccination across multiple populations that we can apply here?
Yes, well, we've done massive vaccination before. Probably the first in recent memory, if you're an older baby boomer, is the polio vaccine that got rolled out in the 1950s. And for those of you who aren't familiar with polio, it was a summer scourge that people greatly feared because there was really no treatment for it. It would seem to recur every summer. Some years it was worse than others, and people really feared for the safety of their children who were particularly at risk of polio. Mm-hmm. And that was the whole March of Dimes approach to mass vaccinate the population. And in that campaign, there was one little misstep related to one of the companies that was doing some of the manufacture that was quickly sorted out. And so the vaccination campaign had actually ceased for a short period before it was reinstituted. And then we also had swine flu vaccine in the 70s. That was one where we learned a lesson of post-surveillance monitoring with cases of Guillain-Barré syndrome that weren't identified in the early studies with that particular vaccine. So we do have experience with it, though, all of these things are unique. There are very, very unique aspects. This is a coronavirus. I'm not sure we've ever done mass vaccination against a coronavirus. Yeah. Eric might, maybe in animals.
Yeah, no, this will be the first. I think, as even mentioned, the polio virus is a great example, and you can look up historically some pictures of people lined up around the block waiting for the vaccine. Maybe smallpox is similar. I think in terms of global sense, we're looking to try to vaccinate the entire globe, and in the smallpox vaccine campaigns in the 60s and 70s is kind of similar to that. I think the difference now really is utilizing social media and other avenues to educate, and this is why this program is great, to educate individuals about vaccines, their long history of safety and efficacy, and where to get the vaccines, and also to educate about the virus and preventing viral infections. I think that's the new aspect, is really to kind of deal with that hesitation that arose with, it's great we have a vaccine in 10 months, but, there are some concerns people had about the safety. Were these vaccines rolled out too fast? And Stephen mentioned the trials, hundreds of thousands of people, shown to be effective and safe, and more safety data will come. This isn't just they'll roll out the vaccine and then that's it. They'll be collecting data for months and years to come to make sure that it is safe, it is effective.
There's been a lot of question, and you both touched on that earlier, in terms of lingering protection, even for people who have already experienced and survived and recovered from COVID. The problems that some have, that's a conversation for another day. But we understand that the protection could be conferred, if you've already recovered, up to 8-9 months perhaps. But the antibody testing has left us a little short. At 5 months, you can't find the antibodies, so now there's a movement to start looking at the T cells, that maybe they have a memory, and that's all part of our immune system. How important would it be to test for T cell response to this to better understand who's protected and for how long?
So I don't know, Eric, if you want to comment on that, and I can add some color commentary, but
yeah, happy to.
You said earlier, we really don't know how long, protection does last. It could be significant, though.
Yeah, I think there's data that's kind of gone back and forth, and with science, I think the only certainty is uncertainty at times, and early on, and antibodies definitely we know are protective against viruses, particularly respiratory viruses, T cells too. So the idea of having antibodies that can bind to the virus and prevent them from getting inside your cells. So I mentioned that spike protein. That's kind of the key the virus uses to get inside our cells to start making more copies of itself. So the antibodies are critical to prevent that process. But how do you stop the virus once it gets in? So the T cells you mentioned, Benita, are cells that our bodies produce that recognize viral infected cells and destroy them. So they're definitely something you want a good vaccine to elicit. The problem with these assays is that they're not very easy to do like an antibody test. So that's something that I think is going to be coming forward. In terms of the antibody response, it seems like there's been some evidence that this level of severity of disease may be indicated how long the antibody response lasts. But I'm hopeful that the robustness of the vaccine-induced responses are kind of be more longer lasting. Mm-hmm.
And we're counting down. We're just at the 3-minute mark. Let me ask a quick question. So many questions about masks. Is this the best? Is there a better that the community can use? If I wear it during the day on and off at work, do I have to throw it out? Can you give us a quick thumbnail on that, on the masks?
So the basic hierarchy is any face covering is better than no face covering, and ideally covering the nose and the mouth. Surgical grade face coverings are better than non-surgical grade face coverings like cloth masks or bandanas or t-shirts or bag over your head or anything like that. And then the highest level of protection really, which is used in medical settings where we're actually caring for patients with COVID-19, is the N95 mask, which requires people to be fit tested for that to be an efficacious approach. And in general, there really isn't a need for N95 masking in the general public, but surgical masks are available and are probably a little bit better of a choice than maybe the cloth or bandana style. And you probably, when you doff the mask, it's best not to touch the outside surface because that's a potentially contaminated surface, and to throw it away and reuse. They're very inexpensive, and they're available in lots of venues now.
Mm-hmm. And before I let you go, we're down to a minute. The home testing, do you think that's going to be a bit of a game changer, or it's just one more tool in the box?
Well, it's not yet widely available. The news came out last week. It's called Lucera. The FDA has approved it, but I'm not aware that it's been into distribution just yet. The good news, though, about that test is it does seem to have a better sensitivity and specificity pattern than what is meaning. It's a better test than the typical rapid testing that we often see in the consumer space.
Gentlemen, I want to thank you so much. I want to thank everybody who took a little time today to join us. And I'm going to reserve the right to call you guys back as we start closing in on Christmas to revisit where we stand and have another conversation. You had provided so much great information. Thank you. And thank you all for joining us. And you can check out our regular Health Beat program. New programs posted every Monday and Thursday right here at WNYT.com. Take care. Have a happy, healthy holiday upcoming.